Good morning, one and all. Today we have very advanced technology to deal with most of the situation. But sometimes still a hammer can do wonders. Sometimes the most ordinary things could be made extraordinary simply by doing them with the right people. I emphasize on the right people. Choosing of people is very important. That is what I am going to present today, collagen cross-linking and contact lens practice in keratoconus, our experience in medical college setup. Collagen cross-linking using ultraviolet light and photosensitizer riboflavin was developed to treat the corneal thinning and ectasia by increasing the biochemical strength of the cornea. A significant increase of 328.9% in the biomechanical rigidity of human corneas has been documented after collagen cross-linking. Treatment modality for the progressive keratoconus at all stages, we all know, and it stabilizes the progression of disease, and it has got an excellent safety profile proven in adults. I would salute this genius, Dr. Theo Saylor and his colleagues in Dresden University, who developed this therapy which has revolutionized the treatment for keratoconus. If you look up the history of keratoconus, surgical procedures done for the keratoconus over 30 years, you can see this is very evident. So we started doing topography around 2015, 2016, and we purchased the CLUVR Rapid in 2016 and started doing C3R. I am very thankful to my previous HODs and also to Dr. Late Krishnankuti, from whom I learned the basic techniques of contact lens fitting. When I started the technique, so many concerns for me, like what will be the acceptability? What about the availability of riboflavin? What will be the cost? And then I set up all the protocols. I was very meticulous in patient selection, assessment criteria, and very meticulous in monitoring and follow-up of the patient. It was in the beginning, I was doing 3 cases with 1 vial of ribocross. That is because of not very speedy availability of the riboflavin. So from the year 2018, we are doing the cases. During the COVID period, we had a regression. Otherwise, we are regularly doing the cases. We started documenting systematically since 2018. And we did a study to analyze the outcome of corneal collagen cross-linking with ultraviolet A and riboflavin in arresting the progression of keratoconus based on the changes in the corneal topographic parameters, refraction and visual acuity, and also to study the safety of treatment modality. We included 78 eyes of patients with keratoconus with documented progression, that is, change of keratometry value of more than 1 diopter over 1 year, or change in astigmatism of more than 0.5 diopters over 1 year. We excluded patients with corneal thickness of less than 400 micrometers, severe corneal scarring, severe dry eye, and pregnant women. And the parameters we assessed before taking the patient for treatment, we recorded the visual acuity, best corrected visual acuity before the treatment, and uncorrected visual acuity, refraction, and corneal topography parameters. This is the machine we have. This is a very ordinary and very basic machine. Only these axial elevation, tangential refractive maps you can have. Only values for comparison is the SIMK value and the KISA index. SIMK is the simulated keratometry in the maximum power of the surface along any axis and the power orthogonal to the axis. KISA percentage index is the product of central K reading, IS value, astigmatism measured by SIMK value, and skewed radial axis index. We know that it is a very effective index. KISA percentage is a very effective index in the identification of keratoconus but may have a significant number of false negatives in the clinical diagnosis and its incipient keratoconus cases, which can suppose a major risk in its use as a screening tool in refractive surgery. But I didn't have any option. The procedure was performed in operating room under sterile precautions. We practiced epithelium off technique. And after a thorough wash of the corneal surface, 0.1% riboflavin was applied for 30 minutes at 5 minutes interval. Ultraviolet A irradiation 365 nanometer for 30 minutes was then performed with 50 millimeter distance from the cornea with an irradiance of 3 millivolts per centimeter squared. Riboflavin installation was continued at 5 minutes interval throughout the process of UVA irradiation. After completion of irradiation procedure, thorough wash was again given, followed by the application of a soft bandage contact lens and antibiotic eye drops. On the third day, BCL will be removed, ensuring complete epithelial regrowth. Topical antibiotic and steroid drops were applied for 3 weeks and a preservative-free artificial eye drops for the 6 months. The patients were instructed to avoid driving for 2 weeks. The patients were followed up at 1 week, 1 month, and 3 month and 6 month intervals respectively with the same visual and topographic parameters, each time warning against eye rubbing being reinforced. Visual rehabilitation was done either with glasses or RGB contact lenses or special contact lenses, for which I used to refer patients to specialists. These are our study results. Age distribution. Youngest age group we did was 11 years and the oldest age group 35 years. The mean SIMK before C3R reduced after 6 months of C3R, p-value less than 0.01, which is statistically significant. The mean KISA percentage before C3R reduced by 6 months after the procedure. This is the comparison of KISA percentage value at different time intervals. And we found that there was a statistically significant reduction in KISA percentage index and simulated K values in patients with progressive keratoconus 6 months following C3R. And this is, in our study, 36.4% participants had complications at first week, that too minimal corneal haze, which resolved within 2 weeks. None of them had any complications in the first month, third month, or 6 month time intervals. So we prescribed spectacles for 44 patients, RGP lens for 12 patients, special contact lens for 4 patients, none for 11, because they are using none, because they are happy with whatever vision they have. And we lost follow-up for 7 patients. So to conclude, early detection of keratoconus and prevention of its progression can be aimed at primary level. Even with basic corneal mapping, refraction, keratometry, and pachymetry, progression of keratoconus can be monitored. C3R is the gold standard and easy and safe procedure for arresting the progression and could be performed at secondary level. Most of the early and lower grades of keratoconus could be managed with spectacles and simple locally available contact lenses. Patient education about importance of regular follow-up, avoiding eye rubbing, managing allergies to prevent progression is very important. Having said this, and yes, well, it seems to be a very simple, but a step behind the most advanced technology. That is why I am emphasizing that you should keep in touch with the specialist with your premises so that you can refer the patient at any time. Thank you so much.
Thank you, madam, for that wonderful talk. Next, I invite Dr. Anita Jabbar to share her insights on the optimal management of keratoconus, challenges and solutions.